Welcome to Doctors at Work. My name's Matt Daniel, and this podcast is about doctors' careers. Today, we're talking about portfolio careers. Now, traditional medical careers have involved staying in the same place until retirement, but more and more doctors are embracing careers based on variety and mobility. In this episode, Daniel Lamb tells me that his own portfolio career involves clinical work in different settings as well as non-clinical work. He outlines that this gives him flexibility, variety, and learning opportunities, and each clinical career contributes to him being a better doctor in the other careers. The different careers meet different things that he desires in his work. He also outlines a mindset that is interested in growth and development and the importance of taking up opportunities as they arise. Finally, we also discuss money. Now, this may be a dirty topic for medics, but in our discussions, we discovered that actually financial as well as physical and psychological health is important if we are to give the best to our patients. Welcome, Daniel. Tell me a little bit about yourself.
Yeah, my name's Daniel Lamp. I'm an Australian doctor working in general practice. I am based in Sydney. I love the flexibility of general practice. I guess what you would call a portfolio GP. I work part-time in kind of traditional GP clinic, but also at the moment doing some telehealth hospital in the home work and also doing some hospital kind of ward cover work just to maintain some of that as well. And I guess outside of clinical medicine, I have an interest in finances and have my own podcasts promoting the idea that doctors need to look after their financial health.
And I invited you to talk about portfolio careers. What is a portfolio career?
Hmm. So basically, I think the traditional thinking is you just, do one thing, one path, and you do that, I guess until retirement. But I think more and more younger doctors and medical students are seeing there's different avenues that you can do, both clinical and non-clinical. So for myself, I think I wouldn't enjoy doing, 5, 6 days a week of seeing, 40 patients a day in a traditional general practice setting. A lot of my colleagues um, talk about, burnout from that. So I guess, you can have other interests in other areas of medicine. As I touched on at the moment, doing some work in the telehealth space and also as well doing some work for the hospitals, kind of state government work.
I'm interested in how you got started in that. Did you wake up one morning and think, that's it, I'm going to have a portfolio career? Or, how did all of this happen?
Yeah. So it definitely wasn't planned as such. I knew in medical school and in junior medical years, tossing up different specialties, considering critical care medicine at one point, such as emergency medicine. But then I wanted kind of, better, kind of more regular working hours and also kind of seeing the impact of chronic disease. So that's why I jumped into general practice training. And yeah, general practice training was interesting. And but even throughout my general practice registrar years, I did a little bit of locum emergency department work, partly to keep up my skills, but also partly to pay the bills as well. So I kind of, you could say, fell into that, or there was an opportunity. And then later, the hospital, said, there's some other work that is ongoing. Would you like to do that? And I was happy working there. So that's how I got into that one. And in regards to my telehealth job, trying to remember actually, I think I might have seen an ad or had a colleague talk about it. And then I inquired. They were looking to hire at the time. And yeah, I've stayed with them since.
And how do the different careers interact? How does one role support the other role?
Hmm. I think staying in the hospital system a little bit and having some of those more hands-on skills and also talking face to face with some of the specialists, physicians, cardiologists, geriatricians, I think does improve my general practice um, setting as well. Sometimes general practice when it's just you sitting in the room with the patient. it can be a little bit isolating, a little bit lonely. So, one thing I missed from the hospital environment was having that more teamwork collegiality. So, you could say, kind of best of both worlds. Obviously, the hospital environment's not perfect as well, sometimes very under-resourced, pager going off left, right, and center, um, running around dealing with lots of different things, bureaucracy, et cetera, et cetera. But I think having a bit of feet in both camps, I think has helped my own personal satisfaction, but I think also made me a better doctor as well.
I'm interested in the phrase "best of both worlds" because best of all worlds, because
Mm,
I guess you could sort of say it's the worst of all worlds, but there's a mindset there, isn't it? So it's so what I'm hearing you saying is that different bits of your career that adds, it meets different needs and it adds stuff into your life. It adds additional meaning and it adds additional satisfaction that one role can't meet. And and maybe the hospital roles, they don't meet. You mentioned your interest in chronic disease. In hospital you won't necessarily see that, but in general practice you won't necessarily have the kind of teamwork. So different roles bring different aspects.
definitely.
Um, the other people that that have portfolio careers, what are the reasons that other people do them? How do other people get into it?
Yeah, that's a good question. I think some of my colleagues that I know do a little bit work outside traditional general practice. Um, I think also as well, the portfolio career has become more and more popular. There's a Facebook group for doctors in Australia. It's called Creative Careers in Medicine. I think it's quite a big group now. I think it could be like, don't quote me, 30,000 members or something. So basically, there is a huge interest in kind of um, careers kind of beyond, traditional, this specialty, that specialty, and these roles are both clinical and non-clinical. I know some people, might do consulting for private equity or pharmaceutical companies or digital health startups. So yeah, so basically there's a lot of different roles and I think a lot of appetite for portfolio careers.
Um, when I did my fellowship in Australia, which was in 2011, 2012, I think that's where for me the idea of portfolio career really appeared, because what I saw was that people worked as doctors, but one day they would be in their private rooms, Tuesdays would be a public hospital clinic,
Mm,
Wednesday private operating, Thursday public hospital operating, or versions of that. So people moved between the different contexts, and they saw different types of patients. They worked with different teams, and the impression that I got was that doctors were much more satisfied, because what I saw is they came and they were doctors, and then they left. They didn't so much get involved in any of the other things that come from being very much embedded in a hospital. Whereas I think maybe the way that we work in UK, most of us probably sit just within one hospital or just within one practice or just within one setting. I mean, the advantage is that you are completely embedded in that department, or that clinic, and that's good. But the downside is that everything that happens then becomes very personal, because it's my department and it affects me. And if there are
mm,
problems, they're my problems and they're things for me to solve. We take ownership of everything that happens, even though a lot of the time it is it isn't stuff that's for us to fix. So I think that's kind of what I took away from Australia, was that idea that people come in, they do the medicine, and then they move on to somewhere else, and they don't necessarily get embedded within one department, or doing everything. But I guess sort of, for you as an Australian, do people miss that idea that you don't belong anywhere? There isn't somewhere that's yours. Do people miss that, do you think?
Um, that's an interesting question. I think what you touched on about, yeah, some of the doctors kind of go to multiple hospitals, see their patients and get out. I think correct me if I'm wrong, but I think that might be the VMO model. So a lot of surgeons and physicians are visiting medical officers or VMOs. I think different states might call them slightly differently. While I know some are staff specialists, and then staff specialists, I think, often have a fixed salary, and also some non-clinical duties, such as teaching juniors, or maybe hospital accreditation, or sitting in on meetings, and things like that. So I think, and there's pros and cons. Talking to some physicians that I work with about visiting medical officer versus staff specialists. Um, but yeah, I'm not sure if that's exactly what you're getting at.
Absolutely.
But
Yeah,
yeah.
that's absolutely it. Sort of, in the UK system, and I suspect probably also in US is, everybody would be a staff specialist. You belong to a department, and you're there more or less full time. Versus the model that I maybe experience on my fellowship was the visiting medical officers. People go from hospital to hospital, from clinic to clinic. So I'm interested, what are your colleagues, what are they when they're trying to decide, people that are, newly qualified and they're thinking, which route do I go down? What are people talking about?
Um, so obviously from my limited experience, some of the physicians have said that some hospitals are now pushing more for the uh, staff specialists rather than the VMO contracts. Maybe it's to do with funding. I know staff specialists sometimes, when they get uh, answering calls or seeing extra patients, they still get paid their, normal salary, while obviously a visiting medical officer, get paid per job or per operation or per patient they see. So I guess they're kind of different models. But yeah, I mean, I don't have personal experience myself. It's just kind of talking to colleagues, and yeah.
I think the advantage maybe of the staff specialist, or which would be the the UK equivalent model, would be that if you're going to be somewhere for 20 years,
Mm,
the advantage is that you can make changes. Yeah,
yeah.
sort of, this is my department. I'm going to be here for 20 years, and then that means that I invest in that
Mm,
department. Sort of I grow it, and then I can contribute. I can make changes. So that's really satisfying,
yeah.
because you
I
can.
think staff specialists also get, yeah, annual leave, long service leave, professional development allowances, things like that. Yeah.
And I guess sort of in portfolio careers, I'm trying to think, are the two models exclusive? I mean, I suppose they're not, because you can be somewhere for 2 days a week, and you
Yeah.
can
Yeah.
do that 2 days a week job for 20 years and grow
Mm.
and develop it. So yeah, so maybe the two models are not as exclusive.
Yeah, I know some staff specialists, it might be 0.2 full-time equivalent, so which would be, kind of like 1 day a week. So yeah.
Okay. You talked about flexibility, so tell me a little bit more about the flexibility that comes in a portfolio career.
Yeah. So yeah, one thing about general practice in Australia anyway is the ability to, within reason, choose your hours, choose your days, and then another one is, if you're trying to, book in a holiday to Japan or Europe, you can just let the practice manager know. You don't need, submit it a year in advance and ask for approval from, head of department, or you know, uh, the medical officer, admin manager, And another thing about the flexibility is, you can choose, within reason, kind of the style of practice. Some people like the slower medicine. Some people, within general practice might have a niche or a special interest. It could be women's health, it could be mental health, it could be skin cancer. It's quite flexible in that regards too, and you can, advertise yourself, and be seen in the community as a, kind of special interest in that area, and then you can attract those patients and build up your own private practice that way. So I guess that's one aspect of the flexibility.
Yeah. Yeah. Okay. And I think also before coming on air, we were talking about the how career decisions might link into burnout. So can you tell me a little bit more about, how burnout affects our career decision making?
Yes, burnout very topical, in the media every now and then. But I think doctors, yeah, and I think there's some studies that doctors in particular, kind of a high pressure job, and rightly so, high stakes, often can have symptoms of a burnout. So for myself, when I was working, 5 days or 5.5 days of traditional general practice, for example, in what's called a bulk billing clinic, where it works on, just from the business model, high turnover, seeing, 40, even 50 patients a day. Um, it can be quite draining at times. And, for those who, just to give a brief explanation about bulk billing. So in Australia, um, specialists and also GP specialists can choose to just accept the Medicare rebate as the full payment from the patient. Unfortunately, though, Medicare payments have not been, indexed to inflation for like the last 10 years. So effectively, if you were just accepting that, it's a, real pay cut. And in the background of, inflation, rising practice costs, electricity, staffing costs, medical indemnity insurance, it hasn't become sustainable. So I found myself, with some symptoms of burnout, working many hours, and also, I guess, and not just the pay. I think it's also the idea of being seen as valuable and valued. So now, so once I obtained my fellowship, reevaluated my options. I decided to just do part-time general practice and also choose a clinic that is kind of mixed or private billing, where patients, pay a private fee and then they claim back that, Medicare rebate from the government. It's really a patient rebate rather than the government paying the doctor directly. So I think that has helped, and also as well pursuing um, other interests, hobbies, but then as I said, also as well, doing some telehealth and also some hospital work. I think just having that kind of, yeah, well-rounded career, I would say.
I hope you're enjoying the show. Please click subscribe so you'll be notified when new episodes become available. This podcast is part of my mission to help doctors create successful and meaningful careers. You can be part of that mission too by forwarding this show to one person who you think might benefit from listening. Thank you. Now on with the show. Let's talk a little bit more about money and finances then. So what's the relationship between portfolio careers and money?
Um, so I wouldn't say necessarily portfolio career by default you can earn more, but I think but it can, for example, you can do some locum work, some short-term work. Often, obviously Australia is a geographically very huge country. And yeah, in a lot of the rural areas, some of the long-standing doctors retiring or cutting down their work, or if they go on holiday, and often, they're without a doctor. And, kind of these short-term locum doctors fill in um, the gap. And sometimes these roles can pay quite a lot of money. And that is one aspect as well. I mean, there are some other, benefits as well, not just monetary, but also, you get to experience a new health system, uh, new way of thinking, possibly different disease pathology as well. For example, if you work up, in the tropics, far north Queensland, Northern Territory, it's um, quite interesting and, different medicine to say, metropolitan Sydney. Um, and yeah, I am interested in finances myself, and I created a podcast called Passive Income Doctor, where basically I saw a lot of my colleagues kind of making, poor financial decisions, often not of their own fault. Just, we're not taught in medical school, and often, sometimes accountant or um, a so-called financial advisor might recommend a particular aspect. And if you just kind of outsource all understanding and just say, here, manage my money, often you hear some horror stories. So that's why a passion project of mine is creating this podcast and kind of raising awareness. And I think, yeah, tying it back to the question, portfolio career allows me to pursue, interests even outside of medicine.
What about long-term job security in portfolio careers?
Yeah. So I guess with security, for example, if you're in a salaried position with the government, such as a staff specialist, or a salaried position with, say, Aboriginal Medical Service, yeah, I guess you could argue it might be higher job security. Although I'm pretty sure even those ones are often, 1 year or 2 year contracts, from my understanding. And I think as doctors overall, would recognize, overall privileged position to be in, with relatively high job security as compared to, say, other people working in, finance or, banks where, if the business goes under, you lose your job. I think with doctors, um, especially at the moment anyway in Australia, there's a shortage of doctors generally, and with an aging population, older population, still quite a high demand for doctors. So I think doctors that are considering a portfolio career shouldn't fear kind of job security. And often as well, all these roles, when I started medical school, which not too long ago, I would have never thought, conducting, just medicine purely through telehealth, and I guess times are changing, technologies change. And I guess if we kind of embrace opportunities with open arms, I think, we don't need to fear job insecurity. We can kind of, yeah, like choose your own adventure, choose your own roles and jobs, build a private practice or improve a hospital system, and you can take action. Yeah.
So this to me sounds like a type of mindset. Yes, because because the mindset isn't I must have this income, I must have this security. The mindset that you're outlining is this is interesting, I can learn here, I can grow there, there's going to be something new and I'm going to jump and take advantage of it. And I won't struggle because there's always going to be a need for doctors. I'll do whatever needs to be. I might not get my first choice of job, and that's fine. I'll do something, but it doesn't matter if it's not my first choice of job because I'll do it for 2-3 years, and then something better is going to come along. So that to me sounds like a very specific mindset based on personal growth and personal development and taking opportunities one at a time, rather than a mindset that says it's all too difficult, I can't do that, I must have 100% job security. Yeah.
Yeah.
Does that sound a fair
Well said.
summary of the kind of mindset you're outlining?
Yeah, definitely. I think obviously, doctors, typically very, high achieving and kind of very risk adverse. But I think, yeah, in life and even our career, we have to still be open to change, and we might set off, yeah, on one particular path, or very set on one particular specialty or one particular role, and then but if you're not successful, I think you can always pivot, and you never know, something else that you end up doing you might really like, and if you don't try it, you won't know.
I think related to that, if I think with my own kind of career development coaching type work that I do in my portfolio career, a lot of that for me initially didn't attract any particular money. I did it because I enjoyed it. I loved it, and that's the reason. But actually, sort of over time, it's something that does generate money. So, if you go into a very clear medical role, then, yes, there is income attached straight away. But equally, I think if somebody's interested, So like, again, another thing for me would be, maybe working in the med tech sector. And again, often for me, that hasn't initially created any income, but then in the long term, it does create income. So it's taking a step and saying, okay, I'm really enjoying that, and I'm going to do it, and I love doing it. I do it because I enjoy it, and yes, I'm not getting paid for it. But often those kind of roles, even then, they still do end up generating income
Mm,
in the long term. So, but the income is delayed rather than immediate. Yeah,
mm.
yeah. Okay, so let's just go back to kind of, you talked about the financial health. Are we as doctors, are we good with money?
So I think, talking to different accountants and financial planners, invariably the short answer is no. And I mean, it's interesting, like where does this stereotype or come from? I think many things. One might be the mindset of, oh hey, during my medical school years or junior doctor years, I don't really need to care about investing or saving money, because once I become fully qualified specialist, I'm going to be making my big money, and then I can care about debts and investing then, and but in investing, the time is so important. Warren Buffett talks about the importance of compound growth, and so if you start investing in your 20s, versus say in your 10 years later, 15 years later, that can make a whole lot of difference later on. So that's probably one aspect. And another, is that can't really blame doctors. Not really taught this in medical school, university. It's often a taboo subject. Like it's kind of not just within doctors, I guess, in lots of societies, not seen as a easy topic of conversation to talk about. How much you're earning and what are you investing, and things like that. And if you don't talk about it, then how can you improve, or how can you generate ideas? Um, and another aspect is, yeah, everyone's got the perception that doctors inherently are super wealthy, but the starting salary when I started as a intern doctor was base salary of 60K, and I think in the UK, from my understanding, it is even lower. Um, and um, so, and this is after, going through, possibly undergraduate university, and then also postgraduate medical school, for example. So you're earning this at, say 25, 26. And by the time you're fully qualified, depending on what specialty, you might be in your early to mid 30s, or even later. So I think the perception that, all doctors inherently earning lots of money is false. And so therefore, we should have an understanding of where our finances sit. We should educate ourselves, and it's very hard. Often, you might be busy studying for exams, or working overtime, and yeah, it's very hard to set aside time to, for example, set a budget, or learn how to invest, or try and find a good accountant, um, et cetera, et cetera. But I think, often we're so busy looking after our patients, that, often we neglect to look after our own, mental health, physical health, financial health. I remember, running around as a junior doctor and, skipping lunch breaks just so you could facilitate early discharge of patients, and, make the nurse unit manager happy. Um, or in a general practice, squeezing in extra patients so then you don't have a lunch break or toilet break, which, I think it's important to put your own physical health as a priority as well. And then similarly, financial health, if we're working so hard and, having a valuable role in society, but then if we make poor financial decisions that set us back, over the long term, hundreds of thousands or millions of dollars, then that's not a very good outcome. So in my podcast briefly, I talk about, turning our active income towards passive income. so that making your money work harder for you, not just you, working 80, 100-hour weeks just to get by.
And there's something interesting there, in terms of looking after ourselves and both, physically, psychologically, as well as financially. That for me, that supports good patient care. Yeah, and kind of I think like, well, how does you go for lunch support good patient care? But it's one of the things that maybe I've experienced in my past career, probably similar to you, is that you run around all the time, and all the time you're giving to others, you're looking after others, and that's admirable and that's very good. The problem with that is it's not sustainable. Yeah,
Definitely.
if all the time you're giving and you're looking after other people, then you're not going to manage to sustain that kind of career in the long term. Yeah, you can do it for 1 year, 2 year, 5 years, but sort of 10 years down the line, where you've skipped every lunch break and etc., and you're unhealthy and you're overweight. I mean, I was heavily overweight at one stage. I mean, not now, but you reached a stage where you're not healthy, and then because you're not physically and psychologically healthy, you cannot deliver for your patients what you might want to. Or worse, you find yourself being resentful because you say, well, all the time I'm doing this, who's looking out for me? So you burn out, you become resentful, and even if you avoid burning out and being resentful, you are not physically fit and well enough. And paradoxically, the very thing that you sort of say, I want to look after our others, that's the starting point for us as doctors. But paradoxically, if we don't look after ourselves, we cannot deliver the very thing that we want to deliver, at least not in the long term.
100%.
I quite like the idea of dialing up and down different bits. Sort of one of my previous podcast guests talk about that okay, I've got exam, it's all about the exam, I'm not going to pay attention to my family and my health because I've got to spend 6 months revising. And then after exam you say, okay, well, that's fine, I now need to look after myself, look after my family, and and I'm just going to work 9 to 5, and it's going to have to do so it's not that all the time you're looking after yourself, or all the time you're looking after others.
Yeah.
It's like, for these 6 months I'm doing that, or Monday, Tuesday I'm doing this, Wednesday, Thursday I'm doing something else. So all the time you're dialing up and down how you're doing different things. So there's something there about balance, yeah, rather than not being me, or not being you, but it's recognizing it needs to go you, me, you, me, you, me, you, me, you, me, and that's the only sustainable thing in the long term. And certainly, the research data, when it comes to burnout, backs that up. That we know that if the more patient focused, altruistic somebody is, the more likely they are to burn out. Yeah, which is just paradoxical, isn't it? Yeah. But if I kind of come back to money, it's interesting that if I think for looking around UK, and in UK we've got sort of strikes at the moment that are about a number of things, pay being one of them, and the I'm seeing that people's basic financial needs are not met. That means that it's not a question that people have a decent lifestyle and that enables you to work, but actually sort of people's basic financial needs are not met, which means that they are not able to deliver the best thing that they can for the patient. So kind of again, going back to your point, how all of that matters, because somebody might say, oh, I want to look after my patients, I'm not interested in money, and you might come back and say, well, actually, but if you yourself are not in a financially good position, you're not going to be in a position where you're going to be able to give. Yeah, sort of.
Yeah, and touching on that as well, I think so general practice overwhelmingly in Australia is private practice, and I guess, which is a business. And, if your business is losing money, then it's not sustainable. So then, there have been instances where general practice clinics have been unfortunately forced to shut. So then, how does the patient win in that scenario? Now they don't have access to a GP service. So I guess, yes, it is providing healthcare and putting the patient, but it has to be a viable business model. So hence, it has happened over the last probably 1 to 2 years, more and more GP clinics are moving away from that kind of bulk billing where the patient pays zero gap towards the, private billing. They might still no gap fee for, certain, young kids or on a case by case basis. But then, I guess similar to, if you have you see your lawyer or see your accountant, usually you have to pay a fee. So similarly, kind of medical practitioners, there's more understanding, I think, in the community that, general practitioners work very hard to get to there, and they provide a valuable job in helping chronic disease and preventing patients from, ending up in hospital or needing, bypass surgery and things like that, which I think unfortunately is often overlooked by the government. But I think it is slowly changing. So yeah, I think it's a good point where, often don't want to talk about money, but in a general practice setting, at least, kind of setting the appropriate fees to ensure the practice is viable, and that doctors as well, have enough to support themselves and their family. On my podcast, I interviewed a doctor who's come from the UK to Australia, who's a proponent of, private billing and, patients seeing value and paying for that. And yeah, it's interesting what's happening over in the UK as well.
So there's a kind of short-term, long-term paradox that we might all say, we want to, of course, we put patients first, and we want to be efficient with our money, and also personal finances. And in the short term, you can do that for a period of time, but in the long term, if things are not financially sustainable, then the very thing that we want to do, which is put the patient first, that disappears. Like with your example of a private practice, the very thing, presumably those practices have said we want to keep the costs down because we want to do the very best for the patients. Admirable, sort of great idea in the short term, but then in the long term, the very thing we put in our patients first, that's the very thing that has disappeared because of poor financial decisions. Yeah. And maybe likewise, on a personal level, sort of if I think, with me, if I have money to invest in myself and I have money to pay for, whether that's holiday or whether that's therapy or whether that's coaching, or whether it's time out, whatever it might be, if I can afford to pay that, that makes me a better doctor, because it means, when I do go into my work environment, whether, I'm rested, I'm happy, I'm psychologically well, I'm well trained, I can afford to do CPD, I can afford to do, additional qualifications, master's degrees, if I want to. But the fact is that all of that's I have the money and time, and often the two are related, so to invest in myself. But by investing in myself, that actually then makes me a better doctor. So the weird thing is, you might sort of say, like, I'm not interested in talking about money, but the presence of money means I can invest in myself, in making sure that I am, in a good thing, that, when I turn up to work, as the instrument of healthcare, that I am fine-tuned, polished, rested in the optimal condition. That means that is the best way that I can deliver the best thing for my patients.
Yeah, I think definitely. And, I guess we're not, well, the reason I invest is not just to pursue, material things. I think a lot of doctors would like to have a bit better work-life balance, work a bit less, spend more time with the family, or be able to afford to spend time doing pro bono work or doing charity work, or, pursuing interests that, don't pay very well. So I guess it's kind of, pursuing that kind of financial independence. The reason, what is the reason? It could, as I said, if it is to spend more time with family or to give back to the community, I think that is a good end goal. So therefore, trying to earn a sufficient wage and also invest as well, should not be a taboo or controversial subject.
Let's bring us to a close, Daniel. What would be your top tips for doctors at work?
Yeah, so I would say looking back on my career, I think it's okay not to know exactly what specialty you want to do straight out from medical school or, first postgraduate year. It's okay to take some time, try out different specialties, talk to a doctor slightly ahead of you or even further ahead of you to try and gauge what different specialties are like. It's not a race is probably my first tip. My second tip would be is to consider working in different areas and different roles. I've talked about how portfolio career I have found very beneficial and rewarding. There's so many different niches and roles out there. I think there's a place for everyone really in medicine. And my final point, third point, would be to take your financial health seriously. Invest. It might be very hard to start, but you can start by reading a book or listen to podcasts. Some well-known investors such as Warren Buffett. Um, you know, Try to talk to some of your colleague and see if they're open-minded about it. You can also, check out my podcast as well, Passive Income Doctor, where I talk about, mindset, and how to choose the correct advisors. And also for those in Australia, one area that I'm very interested in is residential real estate. But definitely, I would say to summarize, number one, it's okay not to know straight away what specialty you want to do. Number two is to try different roles and be open to opportunities to present. And number three would be to invest.
Thank you very much, Daniel.
Thank you. Thank you for having me.